So, good evening, everyone, from the distinguished faculty present here and my colleagues. So, welcome to today's grand rounds. I am Dr. Sarjak Shah. I am presenting a case, and I have with me my colleague Dr. Fathima. She will be taking over the discussion part, and we are presenting under the moderation of Dr. Sudha ma'am and Dr. Suganeswari ma'am. So, to begin with, I'll start with the case presentation. So this case had a lot of follow-up also. So I'm starting from where it is interesting to us. So on that day, patient dates are also marked there. The patient came with the complaint of 15-year-old male child came with the complaint of diminution of vision in both the eyes with floaters in the right eye since 1.5 months. He had developed typhoid fever following which ocular complaint started, and he was started somewhere else on tablets cefuroxime. He had consulted locally, diagnosed as right eye query vitreous hemorrhage and left eye retinitis, and was started on oral steroids for the same. And he was on 20 milligram tapering doses. And also systemic investigation for typhoid IgM, IgG were done, which were negative, but viral was positive. Previous history, he had been operated for both eye congenital doses with frontalis ring surgery, like 5 years back, and he had a negative history of any TB, contact with any TB, joint pain, rashes, or back pain. So on preliminary examination, both eye visual acuity, best corrected visual acuity was 6.9. Intraocular pressure was normal. Anterior segment in the right eye showed some exposure keratitis, some pigments on the endothelium and in the anterior vitreous phase also. Left eye had occasional anterior segment cells. Pupil in the right eye was dilated under mydriatic. He was already on some topicals at that time, and left eye was normal. Both eye clear lens. In the right eye posterior segment examination, the dispersed vitreous haze was there, probably due to vitreous hemorrhage. Disc was faintly visible, and rest findings are not seen. Left eye media was clear, disc was okay with sufficiently large cup, subretinal, yellowish, multiple lesions were there, and both eye color vision was normal. So, suspecting what already was, he was diagnosed as a retinitis. AC tab was taken for Mycobacterium tuberculosis virus, typhoid, and toxoplasma. X-ray was also done, which was normal, and Montauk's test shows strong positivity with bleb formation. His HRCT also showed some changes which were correlating with the hyalin lymphadenopathy. So as you can see now in investigations, right eye fundus picture is not very clear. There is a diffuse vitreous haze, probably due to inflammation or maybe due to hemorrhage. Disc is just visible. On the ultrasound, right eye ultrasound shows the vitreous cavity which is filled with low reflective dot echoes, and more echoes were noted inferiorly. It also shows a variable reflective membrane echoes with good after movement attached to the optic nerve head, suggestive of bloodline PVD. And some mobile low reflective echoes are also present in the subhyaloid space. So now coming to this multimodal imaging of this patient, if anybody has any doubt, you can just ask about anything, if to madam also, to me also. So this left eye multimodal imaging starts with this fundus photograph. So can anybody tell what kind of picture does this look like? Can anybody describe this picture? Yeah, it's just on the posterior pole next to the fovea, temporal to the fovea. Then how will you describe the lesion? It's a color first you have to describe. After that, location, the shape. Then try to identify the extent also. If it is extending to mid periphery, to far periphery, and more anteriorly than that or not. So I'll just show you. These are patches of subretinal flat to minimally elevated lesion, which is also appearing to be multifocal. And it can be active exudation, it can be fibrin, it can be retinitis. It is subretinal because the vessels are overlying the vessels, we can see normal. So another thing in multimodal images, this autofluorescence image. Can anybody tell which kind of autofluorescence image is this? If not this, what all different kind of autofluorescence image can we have? Yes. Okay, so two types of autofluorescence images can be there, and this is the blue autofluorescence or short wave autofluorescence image, and this shows better delineates the multifocality of the lesion. You can see the black lesions multifocally spread on the posterior pole, and it appears as a hypoautofluorescence with a perilesional halo of hyperautofluorescence around the lesion, and all the lesions are within the arcade. So after that, we have done FFA for this patient, and this is an early, maybe early to mid arteriovenous phase. It is around at 57 seconds in the angiogram, and it shows a lesion which is now looking more confluent than it was looking on the autofluorescence and the fundus photograph. And this is just around the late arteriovenous phase. So the lesion is showing blocked choroidal fluorescence from confluent subretinal lesion.
with a pinpoint area of hyperfluorescence within that area of hypoautofluorescence which we saw on the blue autofluorescence image. And in the late phase, which is very typical of like coming to diagnosis, this is a very typical picture. So can anybody describe this characteristic on the late angiograph? This is around 12 minutes of the angiograph. This is a very characteristic sign. Can anybody describe what kind of differential diagnosis can be there from this multimodal imaging? So whatever area was there in the this autofluorescence image, it is all showing late leakage at 12 minutes. So early hyperfluorescence with late leakage, is it that? Can anybody volunteer? So the late image, it's taken at 12 minutes, it's showing a pinpoint area of hyperautofluorescence, which is a late leakage of unspecified source. But that does not come to a definitive conclusion what kind of etiology we're dealing with. But below that, you can see the vessel walls is clearly stained, which shows that perivenous leakage. It suggests of an active inflammation. But I'll ask Madam to shed more light on such lesions and how to differentiate this on FFA. Madam, can you just...
So the most important problem was this particular patient was like, as Sarjak had pointed out, he was on steroid therapy. So at this point in time, for us, as differentials are like how to differentiate if you have a CSCR. Like when you are giving steroids to the patient, how would you differentiate a CSCR from this particular entity? That was the biggest challenge. So like for instance, if you have a CSCR, the leakage should be very well defined. It will be, even if you have a multifocal CSCR, the leakage has to be well defined. Whereas if you see in this picture, though it is in the arteriovenous phase, you can see the picture number 3, the earlier one. See, now if you see this is a very ill-defined leak which you are seeing. That hyperfluorescence is not very well defined. It is more of ill-defined. So when you see something like that, this is coming from deeper to RP. That is what it should show. And as your angiogram progresses, now you see as the angiogram progresses, see how it becomes, the fluorescence will increase. Whereas in a CSCR, what happens is it is more well defined and the fluorescence will increase in time. So this is like more ill defined. It is not going into how it should be. A sharp fluorescence will not be there. That will be a very characteristic take. In fact, this was something like what we had done was, because the steroids were started on, this boy, and Sarjak is going to explain all that, how it progressed and where we got caught with this particular patient. But this was the most important clue, like we are not dealing with CSCR. So the exclusion is important, that we are not dealing with CSCR. So what is the other thing? So the characteristic thing was a very prominent hyperfluorescence which should be there, which should start early on, and it should, as the angiogram progresses, the size of the leak will increase. That should be there. Here if you see, it is not increasing. It is probably just in the same area. It is becoming more prominent. The borders have not become really fuzzy if you see. So that was the clue that we are not dealing with a CSCR.
Can anybody tell what kind of leak patterns will be there in CSCR? And another one is? Yes, so which one is more commonly seen? Yes, ink blot is more commonly seen. So there is no signs of such ink blot or smoke stack patterns here. So coming to the OCT picture, right eye, as said, due to the vitreous haze, the image quality is not very good. In the left eye, this scan is passing through the disc, the fovea, and to the lesion that you see on the fundus picture. So it's an oblique scan, and it shows some hyperreflective material which is non-homogeneous sitting above the RP in the subretinal space. So this is also a clue which can lead to confusion of a CSCR-like picture, because CSCR will also have a fibrin-like deposit in the subretinal space also. But here there is no signs of SRFS present. So the OCT picture is like this. So after that, systemic workup was simultaneously, all of this thing was simultaneously going on. Yes, ma'am.
So see some vitreous cells there. So probably you could think of inflammation at this point. And there is some amount of choroidal thickening also, if I remember right. The
At this
choroid-
point, it was not very significant, ma'am, but on later scans, it was drastically
okay.
increased. So, systemic workup, some more investigations were done. ECTAP that was previously taken came negative for Mycobacterium virus, typhi, and toxoplasma. Serum ACE level was also done, which was within normal range. COVID was also negative, and Epstein-Barr virus panel was also negative for the patient. So then he was started on the anti-tubercular treatment, the common 4-drug regime by pulmonologist based on the HRCT and Montauk's findings. And concurrently, we also started the patient on 40 milligrams of oral steroids. However, it was rapidly tapered because of this confusing pictures on the FFA and OCT. So after that, after tapering the steroids, the patient came 7 days later with complaints of both high DOV and localized pain redness since 2 days associated with periorbital pain. The visual acuity dropped from 6/9 in both the eyes to 3/60 in the right eye and hand movements in the left eye. On exam, both eye had a clinical worsening with involvement of the conjunctiva with proptosis, lid edema, chemosis, periorbital swelling, and new lesions on fundus. And the right eye also showed some abduction restrictions on movement testing. So now when patient presents with this kind of pictures, who was already on steroids with congested eyeballs with periorbital signs, pain and everything, usually we suspect it to be a periorbital cellulitis like picture. It is a very drastic change after tapering the steroids. Why patient stayed on steroids, but this picture is like a very drastic appearance of presentation. Now, if we test the same time after tapering the steroids with such worsening, the patient also showed increase in the SRF inferiorly with active lesions becoming more and more confluent. So it's more deposition of that material subretinal yellow, that lesion is growing more. On OCT, so this first picture in the top shows the first picture when we first took, and the below is progression within 2 weeks. So it worsened a lot. CL OCT, you can see it shows extensive subretinal fluid which is inferior temporal to the fovea corresponding to the lesion which we were describing, and also subretinal exudation with bacillary layer detachment is also seen. The underlying choroidal structures in the top picture, you can see some choroidal vessels are visible which is not visible in the inferior picture, and also some choroidal elevation can be seen which correlates with the choroidal inflammation and appearance of choroidal granuloma which has grown in size. So this is the vertical scan, and the other one is the horizontal scan. On ultrasound, right eye was similar to before, but left eye, in the right picture where the arrow is marked, there is discontinuity of the scleral wall. So in the top part you can see the scleral, the retinochoroidal scleral complex, the shadow is seen, but in the inferior part there has some accumulation of some material which is a hypoechoic organized material which is adjacent to the optic nerve head and involving the macula also. So the image also shows the peripapillary choroidal thickness which is around 2.13 millimeters, and subtenon widening was also seen with the diffuse choroidal thickness. So all these signs points towards the inflammatory etiology. We have subtenon space widening, we have diffuse choroidal thickness which is not consistent with what orbital cellulitis we were suspecting. So MRI is also done to rule out, and on MRI the orbital echoes were normal. However, the T2 image shows a hypointense area in the sclera due to thickened coats. So now we are not very sure what kind of picture this can be. The patient was already started on ATT and the steroids were also started, however it was tapered. So we were suspecting a paradoxical worsening of the patient with anti-tubercular treatment. Physician clearance was obtained for intravenous methylprednisolone. MRI, as I showed, which was normal, and 3 days of intravenous methylprednisolone was given, followed by full dose steroid 60 milligram with 4-drug ATT. Patient was observed for next 10 days, during which he showed clinical and symptomatic improvement. So the visual acuity improved to 6/6 in the right eye and 3/60 in the left eye, and patient after IV MPS, next follow-up was 15 days later. So now this is 15 days after the IV MPS. You can see this is now the optos picture. The right eye, the vitreous haze has reduced and some clearing is seen in the top part, and left eye, still the subretinal material is still there, and on the autofluorescence you can still see the area of hyperautofluorescence which is extending till inferiorly in the left eye. On the ultrasound, now the retinochoroidal elevation which was noted in the previous ultrasound 15 days earlier, which is reduced now. However, diffuse choroidal thickness is still there, and the subtenon widening is also reduced. On the OCT, the right eye picture is more clear. It shows a normal scan. It has improved due to clearing of the vitreous hemorrhage, and in the left eye, the serial OCT shows resolving of the subretinal exudation over time with reduction in choroidal elevation and normalization of the retinal contour with some retinal folds are there. So the patient was continued on the same treatment and asked to review after 1 month, considering the improvement with the current treatment. So he came on the next month with complaints of right eye further diminution. Since 2 days, the vision had dropped from 6/9 to counting fingers at 50 centimeter, and left eye was stable at 3/60. On examination, the right eye had a fresh vitreous hemorrhage with no view of the retina. This is the ultrasound. It shows a moderate reflective dot echoes and few membranous echoes with attachment to the optic nerve head, which is IPVD, and moderate number of low reflective echoes in the subhyaloid space also. So retina appears attached. There is no retinal detachment, but vitreous hemorrhage is with subhyaloid hemorrhage is there. So patient was operated for right eye vitrectomy with band buckling, fluid eye exchange, and anti-VEGF under general anesthesia. Undiluted vitreous sample was taken during the surgery, which was culture negative for Mycobacterium tuberculosis. Gene expert was also negative, and however it came positive for toxoplasmosis. So patient was started on Bactrim for 1 month.
What is the picture during the surgery?
So during the surgery, there was like around the anterior and anterior to superiorly and inferiorly anterior, we had the same kind of lesions which was present in the left eye. So that area we did some, that area we did not touch at that time, sir. We did only vitreous hemorrhage was only cleared, sir.
What was the reason for the vitreous hemorrhage?
So he actually had PVD-induced hemorrhage. So in the beginning he had vitritis was there in the beginning. Then later on the PVD which had gotten induced, that had caused a VTE.
So the patient was on follow-up till 2024. However, the surgery was done in 2020. Multiple injections were given in both the eyes. Left eye was given eccentrics for the same active choroiditis. Left eye was also given Ozurdex for the TB granuloma. Right eye eccentrics was given. After that, barrage was done to the peripheral lesion. Patient developed COVID in the second wave, operated for TB for appendicitis also. He developed PSC in the right eye, was operated for phaco also, phaco with intraocular lens, and right eye YAG-PA was done. And in the last visit, second last visit, right eye was also given eccentrics for the cystoid macular edema. So patient came for last follow-up in November 2024. The right eye vision, best corrected vision was 6/9, and the left eye was 1/30 on Bailey-Logmar chart. Both eye intraocular pressure was within normal limits. Anti-segment was normal. Right eye had a lens with PCOtomy opening. Left eye was clear. Left eye lens was clear. In the posterior segment, the right eye had a scarred juxtafoveal choroidal neovascular membrane with some retinochoroidal scars in the mid-periphery, superiorly and inferiorly. Left eye fundus had extensive retinochoroidal scar which was involving the macula. That's why the vision was poor in the left eye. So this is the last visit fundus picture, montage from both the eyes. Right eye, as you can see, the juxtafoveal lesion can be seen, the pigmented lesion, which is a scarred choroidal neovascular membrane. And in the mid-periphery, you can see the extensive chorioretinal scar. In the left eye, the scar is involving the fovea and extending along the arcades in all directions. So this is the OCT picture, the last visit. Right eye has a normal foveal contour with compact layers, and left eye has a subretinal scar involving the choroid, which is extending till fovea with loss of outer retinal layers and reduced inner retinal diffractivity. So now, if you have any query, you can ask about any of this.
So I would like to ask one question to SKG ma'am. Like if we see some picture like this, which is like a macular choroiditis, so would you feel that our treatment should be more aggressive? Like nowadays we do give moxifloxacin and anti-VEGF in the beginning. So does this qualify for treatment so that we could have prevented such a large scar from occurring? Was that a possibility?
Basically, if you have the pictures in between also, it was a relentless placoid serpiginous choroiditis, which kept progressing as we started the ATT. Now, in 2020, we just knew more about the VEGF and the anti-VEGF injections and Ozurdex to take care of the immune component of the tuberculosis infection. At that time, intravitreal moxiflox, we were not sure, so we have not tried. But in this particular case, it was more of a paradoxical reaction. If you see, after starting the ATT, because he had MAN2, which was a blister, and he had very large lymph nodes, hilar lymphadenopathy. So, according to, like, we have a lot of criteria with which we diagnose ocular TB. So, we decided to do the ATT and the steroids. But suddenly, when the patient came with, I think SRF, that was the time later when I saw the patient, because the patient had SRF, it was misdiagnosed as a CSR, and within 2 days of ATT, the steroids were stopped suddenly. Following which he had a very severe inflammation, which involved severe orbital as well as ocular inflammation, and the choroidal inflammation also progressed. That was the time when we thought that it was more of a paradoxical reaction. The only thing that was a problem here was we couldn't get the PCR positivity in any of the samples, except that, you know, we got the hilar lymphadenopathy and we got the MAN2 positivity. So when you look at ocular TB, it can be either a direct infection of the MTB, which infects the retina and causes the granuloma, or it can be an immune response to the MTB, or it can be a retinal autoimmunity, or it can be a combination of all three. So in this particular case, we felt that the inflammatory component was much more than actually the infection, though the bacillary load in the eye could have been very high to have caused this paradoxical reaction.
So if the same boy is going to present now, would your treatment pattern change? Because at that point in time,
Maybe.
the knowledge was probably not much. But now,
maybe a combination of moxi and VEGF would be the choice right now. But for paradoxical reactions, we just have to take it like what they call now is patient-specific anti-inflammatory therapy. We don't know which component of inflammation is, whether it's the infective component or it's the immune component. So we have to address both, and we have to use the adjunct, the local therapies as well. So we use a combination of all three as of now.
so these kind of reactions are do they qualify into type 3 or do they qualify into type 4 immune-mediated reaction? Because type 3 is usually the immune complex mediated, and type 4 becomes hypersensitivity.
Yeah, most probably is a delayed hypersensitivity, because you are destroying the MTB and the body is throwing up an inflammation, especially the RPE cells. We know that the RPE, which is infected with the Mycobacterium tuberculosis, they've shown in these granulomas as well as in GHPCs. Dr. Rao's paper is also there. Histopathologically, they've shown the RPE the Mycobacterium tuberculosis bacilli in the RPE. So once RPE gets infected, the infected RPE starts triggering the toll-like receptors, and which in turn triggers off the cytokine response, which can be pro-inflammatory or it can be anti-inflammatory. So you will find the VEGF levels high, TNF levels high, interleukin 6, 8 will be high. And so basically what we are trying to do is reduce the bacillary load, and simultaneously we try to dampen the inflammatory response so that the tissue damage is less. That was the aim. So that can be achieved only with a combination, but not with only local therapy. You have to address each case by case, you have to treat it.
So, and how often do you see, ma'am, these kind of this inflammation coming with orbital signs also in a patient?
Yeah, this was very rare. This patient was very rare, but he had undergone a ptosis surgery with sling and a silicone rod, And that was where we got confused whether he was going in for an orbital cellulitis, and we had Dr. BPM to take care of the patient, and with the MRI we were able to sort out that part. So this is one of the very few cases which had orbital inflammation.
So, as Madam discussed, now we can give anti-VEGF in such cases also. So, studies have found that significantly higher mean baseline concentration of VEGF is present in such eyes affected with tuberculosis. So, for tuberculosis, it can present as a macular edema also and granuloma. For both, we can use anti-VEGF. It can help with the breakdown of the blood-retinal barrier in setting of increased pro-inflammatory and VEGF-related expression. So there is one article which identifies the clinical efficacy of anti-VEGF. In this case series, 12 patients showed complete resolution of the granuloma and the surrounding surrounding SRF following the VEGF treatment. Mean 1.67 injections were required for complete resolution of the granuloma, and recurrence rate with monotherapy was around 2 out of the 12 eyes within 12 months of the duration. So the recurrences are also managed with single injection without any need of a systemic adjuncts. So now we give a combination therapy of anti-VEGF with moxifloxacin. This leverages the complementary mechanism of both the agents. Anti-VEGF, which normalizes the granuloma vasculature and inhibits the aberrant vascular development, with ECM deposition, which compresses the blood vessel. So the compression is relieved and enhancing the ATT penetration. And moxifloxacin, when given intravitreally, has a direct availability which and also a preferable accumulation inside the macrophage which harbors the Mycobacterium bacilli, and where it facilitates the elimination of the organism faster than other ATT drugs. So there are two other articles about this combination therapy of anti-VEGF with moxifloxacin. So to summarize the literature, the anti-VEGF with moxifloxacin can affect both the mechanism at interplay here and complete resolution of the TB-related inflammation in the eye. So now I'll invite Dr. Fathima for further discussion about the paradoxical reaction and how it can be diagnosed and treated.
Good evening, everyone. Today I'm going to discuss about the paradoxical reaction. So what is paradoxical reaction? It is defined as a clinical or radiological worsening of pre-existing TB or the development of new lesion on the patient on ATT who showed initial response with the treatment. It is commonly occur at 14% of patient and usually starts within 6 weeks of the initiation of anti-tubercular treatment. It is an immune-mediated reaction following the restoration of suppressed immune response in the host. It is very critical to diagnose the paradoxical reaction because the choroidal lesions can progress and involve the fovea, and ultimately the vision will get affected. So recognition of this entity is essential as it guides the therapeutic decision of continuing the ATT and addition of the immunomodulated therapy or escalation of the corticosteroids. So pathogenesis, it increases in the lymphocyte blastogenesis after the initiation of ATT. So it increases the load of TNF alpha by the macrophages and monocytes. So it will increase the production of pro-inflammatory cytokines like interleukin 6. And so in intraocular TB, the bacteria-laden macrophages will enter the lymphatic system from the lung alveoli, and it will enter the circulation to the eye. So the organism may persist and initiate the immune-mediated response. This is the basic for starting the moxifloxacin intravitreal injection. So the similar reaction happens in the syphilis. It is called the Jarris-Hexamer reaction. It is the endotoxin released from the died organism following the treatment. So that also increase the circulating tumor necrosis factor and interleukin 6 and 8. This causes systemic features like viral features like fever, headache, and sweating increased. So it's similar reaction seen in the HIV is known as the immune reconstitution inflammatory syndrome. It is after initiating the heart therapy, there is an increase in the CD4 count of the patient. So that will cause a rapid recovery of the immune response. So that produce a massive inflammatory response in the HIV patients. There is a role of rifampicin. It is a potent inducer of CYP2C and 2A isoenzyme that is needed for the metabolism of corticosteroids. So it will increase the metabolic activity and 45% increase in the plasma clearance and 66% reduction in the bioavailability of corticosteroids. So it is necessary to increase the dose of corticosteroids while starting the ATT. So what are the signs of paradoxical reaction? So patient present with a decrease in the visual acuity after starting treatment, and there will be increase in the signs of inflammations in AC cells and worsening of vitritis, and there is a progression of new lesions also, or development of progression of the already existing lesion or the development of new lesions, and increases the macular edema, and in some cases it can present as a severe panophthalmitis like signs. So lab investigation, vitreous tap, usually it will be negative for PCR, that will support for the immune mediated reaction, and in CBC there will be increased lymphocyte count, and there will be the exacerbation of the T-Mantoux test because of increased lymphocyte blastogenesis, and we have to test for other co-infection like HIV and syphilis, and if possible like cytokine profile also can be done, like interleukin 10 levels and tumor necrosis factor alpha and interferon gamma levels. So multimodal imaging in the OCTA, there will be increase in the flow void areas in the choriocapillary. So there will be a vascular tuft development that will represent the progression of the disease, and there will be the edges shows the continuous progression and will help to grade the changes in the inner choroidal vessels. So FFA also shows the signs of vascular complication like signs of vasculitis. In OCT, there is a progression of choroidal granuloma or increase in the choroidal thickness or neurosensory detachments and accumulation of any hyperreflective material in the subretinal space. These are the article, Camilo Canary et al. Reported 3 cases of ocular TB with paradoxical reaction, one with the multifocal choroiditis and other 2 with tubercular granuloma. So all the 3 were responded well with the escalating dose with the corticosteroids and maintained on ATT. This is another article showing the progression of the chorioretinitis. The last picture showing the increase in the size of the lesion. This is an in-house article, a paradoxical reaction. The images in that article showing the progression of the new lesions. So main differential diagnosis like treatment failure or poor compliance with the ATT. Treatment failure mainly due to drug resistance, that will be identified by gene expert testing for rifampicin resistance or rifampicin and isoniazid resistant. So it may show the positive cultures and it shows a poor response to corticosteroids also. So we need to test for the resistance by means of gene expert testing. And there is a poor compliance with ATTs, irregular treatment. His history taking is very important. Irregular treatment, resolution with the proper treatment will happen, and recurrence within the period of improvement. So thorough history is very needed for the ruling out the differential diagnosis. So another is important CSCR. So there will be inflammatory signs will be absent. The lesion pattern as early suggested, it is like we will see the pattern like smokestack appearance or ink blot appearance in the FFA, and OCT shows the pachychoroid features with the subfoveal SRF with PEDs. So all those things, and the steroids will worsen the CSCR, and in case of paradoxical reaction, steroid will improve the lesions. So treatment, Basu et al. Found that progression of the inflammations like after starting the ATT in 24.5% of the patients of intermediate uveitis. So all patients respond well with the escalating doses of corticosteroids. Banzar et al. Reported 14% of patients with SLC responded well to steroids and immunosuppressive along with ATT. Fonoloza et al. Described the use of intravitreal dexamethasone implant for active uveitis with CME and retinal vasculitis. Jain et al. Described the use of intravitreal bevacizumab. It showed a marked improvement in the size of choroidal granuloma, and also it played a role in the reversal of subretinal fluid. So it is crucial to continue the ATT and start the corticosteroids concurrently with ATT and along with, if needed, immunosuppressive agents. So this is summary. The ocular lesion in the patient on ATT, if showing a worsening of picture, if we have to note any insufficient inflammatory therapy, we have to increase the steroid dosage or add immunosuppressive therapy. Or if it is like development of new lesion with drug resistance you are suspecting, you have to do a gene expert for rifampicin resistant assay or line probe assay for rifampicin and isoniazid resistance to find out. If it is negative, we have to look for paradoxical worsening. If it is incomplete diagnosis, we have to revisit and reassess for the diagnosis. So So it's a conclusion, significant challenge in the management of ocular TB. So early recognition is crucial. It prevents unnecessary modification or discontinuation of the ATT regime. Awareness of this entity and its manifestation is essential to ensure the optimal visual outcome. Timely institution of the corticosteroids and immunosuppression can lead to the restoration of the vision with maintained ATT. So these are the differential for the references. Thank you.